Dear friends, dear ELPA members, I'm absolutely delighted to welcome you all to the launch of the Euro Hepatitis Care Index here in Brussels. Today is a very important moment for the European hepatitis patient community, but also for me. It was already a long time ago, 18 years, when I took the decision to contribute to the battle to fight viral hepatitis in Croatia. At that time, the disease was largely unknown and access to care was extremely limited. With this in mind, in 2000, Hepatos, the first Croatian liver patient association, was founded. Probably my experience is similar to the one of other colleagues who are here in this room today. I want to thank them for all the effort they have done till today, and I encourage them to continue advocating for better hepatitis care across Europe. I have been the president of ELPA for over 1 year. This has been a very intense and great opportunity to drive policy change across Europe, and of course, this has been possible thanks to a great team of committed people. Thank you all. We will continue promoting the interests of people with liver diseases at European level. Today is a milestone for the hepatitis community. We are here to discuss the findings of the Euro Hepatitis Care Index. I also want to seize the opportunity to especially thank the Cyprus presidency of the EU, who has been extremely supportive and that it is here represented. This is a strongly symbolic action for the hepatitis community. Health Consumer Powerhouse has been commissioned by ELPA to produce this study. For more than a year, the HCP team, and very in particular Beatrice and Arne, have been working very hard interviewing public authorities, patients and clinicians to produce this solid study. You should have received the executive summary in the welcome package at the entrance. This index is a tool to empower people like us, patients, but also physicians, to promote national plans in the field of hepatitis B and C in their respective countries. This index shows policy shortcomings in hepatitis care in all member states. It also highlights some best practices. Like Health Consumer Powerhouse, ELPA believes that development of patient empowerment action promotes and stimulates policy change. I am convinced that empowered patients can drive policy change. Today, speakers are invited to respond to the question on how can we address the viral hepatitis challenge more effectively across Europe. This will be the question driving the series of discussions held during the day. The launch event is composed of 3 main sections before we can enjoy the reception. First, introducing the Euro Hepatitis Care Index methodology and findings. Then addressing the challenge of viral hepatitis across Europe, learning from best practices. And finally, what does viral hepatitis mean in Europe? Advancing a collective response. Now, I'm happy to give the floor to the speakers of the first panel. This will be moderated by Professor Wedemeyer, former EASL Secretary General. But before that, I would like to welcome our good friend, member of the European Parliament, Marina Yannakoudakis, who has been very supportive in addressing viral hepatitis care in the European Parliament. Marina, the floor is yours.
Thank you for inviting me. I'm really pleased to be here. First of all, I'd like to say thank you because I'm delighted to be here at the launch of this event in Brussels. As my party's spokesman on public health, and as a full member of ENVI, I'm aware of the grave challenges which hepatitis continues to pose to patients and healthcare systems across the EU. And events like this provide a great opportunity to harvest the value added we can get from learning best practice across member states. When I read the list of speakers' biographies today, I was enormously impressed by the breadth and depth of the knowledge they're going to bring to this event. I'm sure that it will prove to be tremendously educational for all, and particularly for public policy practitioners such as myself. I say this although I'm going to have to leave, but I will be catching up with people later and going through everything. Access to the best available medical research and information is an absolutely essential tool for national and European legislators in order to develop objective, evidence-based and specifically tailored solutions to questions of public health in our member states. The protection of public policy is of paramount interest to us all, and none more so than with regard to the hepatitis care. Achieving a gold standard of hepatitis care provision requires coordinated programs and action which can come to the aid of patients from all walks of life. Screening plays a central role in preventing the spread of viral hepatitis, yet I am saddened to learn that even in these countries which have performed best in this index, the rate of detection can sometimes be less than 40%. Indeed, a majority of patients in some countries, more than 80%, are unaware they carry the infection. As we all know, when diagnosed and treated timely, we have an excellent chance of controlling and even curing the disease. Yet it remains incremental of our health systems that so many patients are frequently left to develop following diseases, such as liver cancer. These are truly shocking statistics which can only serve to underline that to tackle threats of public health care, we must not be afraid to open our eyes to best procedures and practices in other member states, which could ultimately prevent unnecessary loss of life. Speaking for my own country, I am pleased to see the UK has performed extremely well in developing effective care delivery, but much more needs to be done. In order to achieve this, I am conscious we can learn a lot from the approaches of the likes of France and Germany in terms of developing a truly integrated national hepatitis strategy. I also note that Germany has proved itself to be a European leader in the prevention and access to treatment. So I'll be interested to see how we can tap into their best practices and how we can all benefit across Europe, not only in the UK. Viral hepatitis is an infectious disease which knows no borders. Yet this index shows that it really does make a difference whether you live in one member state, which is a high protection, or in one which is struggling to combat the disease. I am pleased to note that ECDC has finally recognised the gravity of the situation and will be developing a toolkit which will help member states improve the effectiveness of their screening procedures. We can only hope that member states across the EU will take its recommendations on board and implement measures in line with the report's findings. Only by taking a more rigorous approach to screening can we hope to boost the low levels of detection across some of our member states. So in summary, I'd like to congratulate the European Liver Patients Association, the Health Consumers Powerhouse, and the European Association for the Study of Liver for their powerful work in pulling together all this data into one easy, accessible index. On behalf of my fellow MEPs, I sincerely thank you for the vast amount of time and energy which you have devoted in pressing the public health concerns. I know that I, for one, will be studying its conclusions in detail, and I look forward to handing over to the experts who are really going to discuss this subject in a more technical way, I hope, than I have. So thank you very much, and good luck with the event.
So, dear Tatjana, dear members of parliament, dear friends, thank you very much. My name is Heiner Wedemeyer. I'm from Germany, and I've been leading the European Association for the Study of the Liver from 2009 to 2011, and I'm glad to represent EASL at this meeting. I also have to give you the very best regards of Professor Mark Thurst from London, who is the current Secretary General. Unfortunately, due to emergency issues, he was not able to make it today. But I can really tell you that EASL is strongly supporting this event, and we have been working together with ELPA for quite some years. Usually at these kinds of events, people start complaining there's not enough money, we need support, we want to ask for something. But I first want to start that we have achieved altogether lots. With all the stakeholders in place for the last 3, 4, 5 years. We have achieved a lot. 5, 6 years from now, hepatitis, liver disease, have you been aware of that one, that this could be a problem? Now people have started talking about this, and I think this is very important that we first of all realize that liver disease is important. But from this now we have the chance to move ahead, and we can only move ahead if we work together. And this involves obviously patients, this involves us, the doctors, it involves all other stakeholders in Europe, and you have heard already that the situation is quite diverse in European countries. For us, leading the Liver Doctors Association in Europe, it was already challenging to talk about guidelines, and we'll later on address this issue. Guidelines to treat hepatitis are so diverse, so it was our job to have established guidelines. But it's much more than to establish guidelines. We have to identify the patients, and we'll come back to this in an issue. I just want to highlight in the beginning that we have to do a lot. This week I saw from Monday to Thursday at least 7 patients who showed up for the first time in our department and who were there with hepatitis, infections and cirrhosis. And it was so awful because these patients had signs of liver disease already 10 years ago. And it was simply not diagnosed, and they have been screened too late, they have been treated too late by the doctors, they did not receive the appropriate diagnostic tools, and we're talking about Germany. And hepatitis is a diverse picture, and we have to have tools to really address this in an appropriate way, and therefore I think this index is one of the important steps that we have to address to really improve treatment of patients. And before introducing Beatrice, I want to highlight one issue why I think this is so important. And when we talk about treatment, we doctors, we measure efficacy of treatment. This is good, and this is what we are working on, efficacy to improve treatment responses. But in the end, efficacy does not mean effectiveness on the population level. And what do I mean with this one? We are working on efficacy, we improve treatments, but effectiveness does also include screening. If I want to apply a treatment, I have to identify the patient. And if the patient has been identified, I have to apply the appropriate diagnosis. And then in the end, the doctor and the patients, they have to understand that this means there might be a reason to treat the patient. And then the patient has to understand this. They have to understand the consequences. They must be willing and also able. They have to have the resources to start treatment. And then finally, if they start a treatment, they have to adhere to treatment, which is another problem when we talk about lifelong treatment. So this is obviously what we are talking about today, not only about efficacy. So where we are right now, the ideal scenario would be to have a drug that works in 19 out of 20 patients. And we are there. We have achieved this at least for hepatitis B. We will be there in a short time for hepatitis C. Let's assume, wonderful country, 85% of patients have been screened, and then you see all these wonderful numbers. If you multiply all these numbers, then only a little less than half of the patients in the end achieve appropriate treatment. What could be a realistic goal where we should aim for? And you see these numbers, 50% of screening is quite good for some countries. And again, you see these numbers, 80, 80, 80, which is reasonable. Then you end up only with less than 20%. And where we are right now, what do I think? I think we have good drugs, but maybe in some countries only 20% are screened. And you see these numbers, which are not bad for some countries. And when you read this index, then the numbers on the first view look reasonable, but these are the numbers maybe where we are, at least in Germany. And then you end up with 2%. And I think this is why we need not only to work improving drug efficacy from 95 to 97%, we need to identify the other shortcomings in the treatment, and therefore I really appreciate the work that has been initiated by ELPA, and therefore now it's important to listen to this report, and Beatrice Cebolla worked on this, worked on this for the last 10 months. I think the data set is very interesting. We have quite some time to discuss this data set from the views of the different stakeholders of the different countries, which is very important. And Beatrice will introduce now into the data set that she has generated together with Arne and supported by others for the last 10 months. So it's your stage, and we are looking very forward to this data.
Hello. Yeah, thank you. First of all, I would like to thank you very much for inviting us to be here today. It's a big pleasure to have the chance to present the project we have been doing in the last 10 months. The whole thing started last January in a kick-off meeting. It was an initiative from the main European patient organization, ELPA, that together with Health Consumer Powerhouse, a think tank based in Sweden and with a lot of experience in this kind of projects, agreed to bring a bunch of the best data possible to show an overview of what happens in the field of hepatitis B and hepatitis C. We have been extremely supported by the European Association of the Study of Liver, and from here, thank you very much. So the three parties together, we started a project. The tool pretends to empower patients and physicians through comparing and reviewing the healthcare provision and the policies regarding hepatitis C and B in all European member states, plus Switzerland, Norway, and Croatia. The idea is to increase mainly public awareness, create discussion, and point the good and the weak, and especially the good performance. Just concentrating the best practice. We can always learn from those and try to copy. Increased transparency and comparability is one of the reasons of benchmarking and the results of benchmarking. At the end of the day, what we are trying is to help European citizens to get the best care they can get from their countries. The index is based on a number of indicators that has been very carefully selected with a number of experts that I will introduce to you in a second. The index concentrating indicators that reflects properties and performances of healthcare systems. We try to measure characteristics that can be changed by healthcare decision makers. And at this time, in this project for the first time, the indicators has been scored by the expert members in a systematic and coordinated manner according to scientific soundness and measurability. Here, very briefly, I don't have time to go through all the expert panels that have been very helpful and they have been supporting us in these 10 months, but I can tell you we have 3 members representing ELPA. We have also experts in pediatric hepatology. We have, probably you are more or less familiar with many of them. We have hepatologists. We have a head of infectious diseases unit. We have Professor Rosol from Germany, who is also, apart from internal medicine, head, also experts in health economics. And together with them, we had been doing this project. The indicators are divided in different subdisciplines: prevention, case finding and screening, access to treatment, process, national strategy, patient involvement, and right and outcomes. At the end, we started the project with 37 indicators, and because of good quality data, we actually end up with a lot less. The data. We get the data mainly from interviews, from different kinds of meetings with ministry representatives, with national health bodies, with epidemiologists, representatives from public health institutions, representatives of prisons, and also for the first time in this kind of projects with a lot of clinicians. It's very important to mention that a lot of clinicians, more than 100 clinicians, have been participating from all over Europe to give their opinions and to tell us what are the normal practices in their practice. Also for indicators, they come from hard data, so from databases. For example, the one harm reduction in prison comes from World Health Organization, Health in Prison. Also, there is used as a feedback, the data from ECDC in vaccination coverage, but it has been an update from the countries. Data from the European Monitoring Center of Drug and Drug Diseases is there about hepatitis C facilities. And once the data is collected, what we do is what we call validation. Validation means we send to every country the possibility, we send the results, and we give the country the possibility and the opportunity to review their own preliminary results, with the idea that they give comments back or updates. This time, additionally, to send this to ministries of health and national health agencies, we send it to all branches from ELPA, with the idea to also get feedbacks and their opinions about the results we had gathered. In parallel with that, from the beginning of the project, we designed different surveys. One for patients and patients' organization that has been managed by a company expert in this kind of surveys online, which is called Patient View in England. And then a survey to physicians. One more asking questions about hepatitis care, and the other one about vaccination and testing. The first time that this survey was mentioned, it was through the newsletter from EASL that monthly sent to the EASL members. Additionally, and later on, clinician societies had been approached and knowledgeable people all over the country. All over the countries. And also ELPA has been distributing these surveys through their clinician contacts or the persons they thought that it could be interesting because they would be a knowledgeable and interesting point of view. The country validation has been very successful, only missing in the Czech Republic and in Hungary. The scoring system is the next. In every indicator, we get 3 different criteria, and the indicators are scored according to these criteria. There will be a good performance in that particular indicator, or an intermediate performance, or a bad performance. To make a ranking at the end of the project, we include some number, a 3 if the performance has been good, or a 2 if it's intermediate or red. And to make it more graphic and more easy to be followed, as you have seen in the executive summary, we made some colors, green, yellow, and red. Additionally, you will see non-applicable in those cases that the question is not related with the country, and non-available that you will see a lot, especially in the subcategory of outcomes. If a country performs extremely good, which we haven't seen so far, and get green in all indicators along all subdisciplines, then they will get a maximum of 10 points. And the minimum score, it will be 333. Additionally, every subdiscipline, depending on the relevance inside of the disease and the quality of the data we collected, had a relative weight. In this project, we highlight the prevention, the case finding and screening, and access to treatment. Normally, the relative weight in the category outcomes, it would be a bit higher, but because of the nature of the lack of quality data all around Europe, we have to put it down. Before I go into the results, I want to keep you in mind some characteristics. When I'm going to talk about best practice, I don't really mean it. I mean better practice than other countries, because in the whole European community, we are far from being in an optimal position. A lot of Europeans die still from various hepatitis-related diseases. A lot more than 23 million people are estimated to live with chronic hepatitis B and hepatitis C. And the worst thing of that is that most are carrying the disease without knowing it. They don't know they are infected, they don't know they are infectious, and they cannot benefit from the new treatments. And they cannot improve, therefore, the quality of life. The low detection rate is very low in the whole Europe. When we talk about the best practice, which probably is France, we talk about 40% of detection. If we talk about the UK or Germany, we are talking about a detection rate between 14 and 80%. And most of other countries, we talk between the 3% and 0.3%. Additionally to that data, chronic hepatitis is often left untreated, and I will go in detail why and the reasons behind that later on, with less than 20% of the people being treated. This means that, therefore, it is the major cause of liver cirrhosis and primary liver cancer. I want you to take conscience that the data presented here today mainly represent only those citizens with medical card, with health insurance. Because if we think about the majority, for example, of the persons infected with hepatitis C, injection drug users, they are in a marginal position. If we talk about migrants, especially illegal migrant situation, it will be even more alarming. That's what I'm going to represent here. So where do we find the best practice in Europe? France has we found the best practice in Europe with 872 points out of 1,000. The second position, and I know at the moment you are very surprised, but I will go in a second in detail, is Slovenia with 827, and in the third position it will be Germany with 797 points. And then it's coming a number of countries that they are very close in their scoring with each other, and any alteration, any change in any of the indicators can modify the ranking. Therefore, I will ask you to concentrate better in the findings and which kind of information we found better than in the ranking. Of course, it's relevant if the country of interest is in the top 10 or in the middle of the ranking or in the bottom, but not if it's in the number 13 or 14, because that can change. That could change very easily. But what are they doing well? Well, France, as we hear before, is the only country, I repeat it, together with Scotland, that has implemented already a national strategy. And that has the consequences. Between the strategy is already written that mass campaigns are, that are taking place every year. They approach general population, population at risk, and healthcare workers and social workers. Additional for that, as I mentioned before, the case finding is the highest in Europe, and they offer different plans to approach population at risk to test different populations at risk. The access to treatment is excellent. They are improving now the multidisciplinary approach, and every time they have more nurses that they are trained, and they follow the patients and help them to get better adherence and better results. And France is the only country that could report data in the 3 indicators in the subdisciplines outcomes, and is the only one that got greens in the 3 indicators. The second position is in Slovenia. It's probably a surprise for most of you. Slovenia has a very bad surveillance system, very poor epidemiology data, but because it's a small country and with a very small population, the whole management of the disease goes in hospitals. It's all in hands of very dedicated clinicians that always, as they say, the head of these clinicians, they are following very strictly the ESIL guidelines. I have here some data. I got the positive data from Slovenia. They have around 28.1% of detection rate in hepatitis C, 50% of hepatitis B treatment, and almost 40% of hepatitis C people getting treated. That is very much above the data I just mentioned before. Apart from that, they have several testing programs for population at risk. The access to treatment is one of the best in Europe. They were one of the first, including the new treatment for hepatitis C in high amounts. in case people need it. And and then in the third position is Germany. Germany has one of the best prevention strategies, is very good at vaccination coverage, approaching a population at risk for vaccination of hepatitis B. Also one of the best examples of harm reduction in prison. The case finding is also one of the highest, as I just mentioned before, also with many plans to approach population at risk. And as is characteristic from the German country, also in other diseases, the access to treatment is also pretty good. And now let's go through the areas of improvements after these 10 months of very intense work. A lot of people, as I just mentioned before, it's unaware of their condition. So what we need is a public awareness all over the place. Public awareness probably, and I didn't write it here, to health officials, so they can help with public awareness in general, to public campaigns for general population. Every country should design their own campaigns to approach the risk populations, and also health and social workers. We need to the awareness of nurses, physicians, public health experts, NGOs, and other social workers. It was very disappointing to find that public awareness campaigns are in hands mainly only of societies and NGOs and patients' organizations. The governments are normally, or in a very few countries, not supporting these campaigns. And that it means that it's not in the priority agendas of the countries, hepatitis B and hepatitis C. Effective hepatitis B vaccination programs need to be, are very good already, the coverage in infants and adolescents in those countries that offer it. But it's very disappointing to see that vaccination to population at risk is far from being optimal. And I'll show you data. There are always two populations, especially commercial sex workers and MSM, men who have sex with men, that they are completely forgotten, with a very few plans in place, and normally in hands of NGOs with a very short-term budget. The vaccination should be free for all these groups, otherwise we are preventing that those populations at risk decide to get vaccinated. The situation in prison across Europe has a higher prevalence of hepatitis C, hepatitis B, and HIV because of their use of drugs, tattooing, and other risk behavior like sexual risk behavior. The prison itself is a very interesting setting because we approach part of the population that normally will be very marginalized and will not approach the normal healthcare system settings. Therefore, it's a good place to increase awareness among this population, and maybe when they get released, they can take it to their own fellows. We think vaccination should be offered, testing should be offered, all in a voluntary manner and with pre and post counseling, so the person make an educated decision and know exactly what can happen in case they get a positive result. And of course, if it's needed, then treatment inside of the prisons, and when they get released, support to follow the treatment on the street. We also measure the harm reductions in prisons. And I don't have the time to go really through it, but in the East European countries, it's very sad to see that none of the measurements we want to achieve, it was in place. Substitution therapies are not offered in all these countries. Countries like Cyprus, Czech Republic, Latvia, Lithuania, and so on, they do not offer any of these. They do not offer free condom distribution, no substitution therapies, not disinfectants for needles, and of course, like in most of the countries in Europe, needle exchange programs. Some other area of improvements, and that was one of the general complaints we had been hearing in these 10 months, is please, we need qualified professionals that know what hepatitis is. Many health providers do not screen people for risk factor and do not know what to manage with these infected people. They just don't know what hepatitis is about. So we need especially trained for primary care doctors, for nurses, and for other like pediatricians that can increase the awareness and maybe the coverage of vaccination B. for NGOs workers and social workers, people in drug centers, etc. Testing is another area of improvement. General practitioners are essential key players for improving case finding among general population because of their relationship with the families. They are aware of the situation of the family, the history, etc. Testing should be available and easy to access for all members of the community. However, when we check for the points of the facilities to get tested, as you can see, we ask for a free anonymous hepatitis testing and counseling, and only 6 countries out of 30, they are offering this free anonymous hepatitis testing. Mostly it's not for free, or it's not anonymous, or it's just not very easy to find. Maybe 1 or 2 in the main capitals, but not in the small cities. And a lot of countries, they do not offer even that. If we look at the data for hepatitis C testing in the community, which is coming from the European Center Monitoring Drug and Drug Addiction, you see that the results are basically the same. It's also not enough testing points. How are the people supposed to access the testing? Testing in the main risk groups is far from being optimal in Europe. An overview of the different countries shows that neither screening policies, neither guidelines recommendation or systematic practice by physicians provide good coverage of the whole spectrum of an individual at risk. We provide in the report these 2 tables that are not part of the scoring. And you can see, I just show you the gaps, but basically you can see that there are just gaps in, well, they are mainly like commercial sex workers and MS, where basically none of the countries provide plans for them to get tested, neither in hepatitis B or hepatitis C. But in hepatitis C, still other populations are also extremely forgotten, like prison population, like migrant population, and like, for example. Some other area of improvement is treatment. Here it's important that the physicians note which drugs are available and which drugs are the best to be used in, for the patient in particular. But it's also important that the countries, they start to use that ESA recommends in their guidelines and not very old-fashioned drugs that have not that good effect. It is important that the patients, they have access to care. Maybe some of them, they don't have access to normal settings. So one recommendation could be to provide those drugs in non-conventional settings, like outside clinics or hospitals. And it's also very important that the patients, they have access in a money-wise, I mean that they can pay the treatment. If they cannot pay it, they cannot get treated, right? And finally, a trained professional can increase the adherence and the results of the treatment. Many countries like France, for example, is using very well-trained, many other examples, like in Manchester, for example, very well-trained nurses. These trained nurses, they accompany especially those patients with more social problems to follow and explain to them and give health education to the patients. And eventually, these nurses, they also train some other parts of the society, like persons working in the drug center. So what best practice show is that the multidisciplinary coordination and the approaches from different sides, it helps to increase adherence and the results of treatment. Good data availability of quality data in Europe is not very good. The data is often not collected in a national-wide and is normally only regional or only in some hospitals. Limitation in the comparability of some of the data collected is also a problem. Here I want to show you the data we collect on hepatitis liver disease registry. Only 1/3 of the countries have this kind of registries. Some countries, they only have it either regional or it's just not updated. I hear examples that say every 5 years we update it. I think that's not very helpful. And many other countries, as you can see in red, they do not even offer, they do not even have these kind of registries. I wanted to show you here the subdiscipline outcomes and the 3 indicators in outcomes, because the lack of quality data. All these ANAs, they are not available, that comes direct from the country, and they are nationally reported, not available data, not collected data. And look how many of these are in these indicators. Finally, we want to suggest the European Union to take a leadership movement to establish some European strategy that will set the standards and encourage members of states to develop and implement their national strategies. This is the current situation in Europe. The green belongs to France. This is the only country, together with Scotland, which we have to put together with the UK. That's why it's not in green. France is the only country with a national strategy in place. Bulgaria make already, as we will hear later, the first steps to have a national strategy soon. England is developing their strategy in liver diseases, and it will be ready in 1 or 2 months. And Scotland has already, as we also will hear later, the strategy running, and very, very good running. Finally, I would like to remind you that the full report, additional information, graphs, indicator, descriptions, etc. is free access on our website. From here, I would like to thank you, ELPA and all ELPA branches, all the clinicians, National Health Institute, public health persons that have been really supportive in this. Margaret Walter, I don't know where she is, there. Thank you very much. It has been great from ESL. She has been extremely helpful during these months, and of course, thank you for being here and for listening to me.
Yeah, thank you very much. First of all, thank you very much, Beatrice, thank you very much, Anna, because the cooperation over this year was really good, and the learnings for a patient organization is very good, because it's the first time that we now have a systematic analysis of what is the situation in Europe. And so I like to summarize from a patient perspective now the findings of the index, and it's very short, because in our point of view, the situation in Europe is bad. So there are significant shortcomings in all categories across all countries. There's no country, even France, that has a really, really good situation. We still have, as we heard, a very high prevalence of viral hepatitis. We have a very low detection rate due to lack of consistent screening programs. And especially in the high-risk groups, there are no activities, or only rare activities. And this is something, as Beatrice mentioned, we have to improve it. The other thing is we are now going to face that all of these unscreened patients, we have more and more patients with cirrhosis and hepatocellular cell carcinoma, liver cancer. And the other thing is that across Europe we have very indifferent access to treatment. And this is something that we have to work on, and these are one of the key findings here from the index itself. And so, based on the results of the index, I think, so from a patient perspective, we have 3 main areas to work on now for the future. The first is general the lack of awareness of risk of transmission is possible among the high-risk groups, but also in the general population. Hepatitis is underestimated in all areas of the social life. And the other thing is that we need a free and fair access to testing and treatment. Because one screens, so we need the possibilities that the people have the access to the good drugs now on the market. And as Heiner mentioned, so we have very effective treatment options now, up to 95% in both cases, hepatitis C and hepatitis B. And the other thing, we still need data. Because in some countries, even the government, when I met the ministers there, they are not aware of the situation. And so we need data collection of what is the situation of hepatitis across Europe, but also specific in the several countries. we like to offer now, I think, with this instrument of this index solutions. Because I think one of the solutions could be that if we have more national strategy plans focused on the 3 areas of improvement, these are the best instrument for the future. So that if some ongoing activities in the country are harmonized in a strategy plan, and I like more the word action plan, because strategy plan is something that is maybe 2020 established, I need action now, then I think we are in a good way. The other is, now we have across 27 countries, plus Norway, Switzerland and Croatia, so the individual best practice examples that exist. And this is something we can build on. And so we do not have to think about it again and to renew the wheel. We have this best practice already existing, but now we have to put the best practice that exists to put into one strategy plan to a country, and also in European countries, and the European approach, but also on a global approach as well. And the other thing is, this is all the time very important, and I think Alpa is one of the good examples, that patients' empowerment is part of the solution. So the more knowledge patients have about their situation, but also about ways of solution, I think we can increase the situation very much. And other thing I like to have for the future is that patients are involved in the design of a strategy. Because it cannot be that from top-down strategy plans are developed without patients included. Because patients have the knowledge about the situation. And if patients, together with the physicians, work on a strategy plan, I think then we have real good strategy and action plans. And just very, very short, I think now with this instrument of the hepatitis index, we have developed now an online thing you can play with. Because what we have listed here is very simple, it's the web page of the index itself. So, first of all, everything Beatrice explained is listed here, and we have this index map. And the index map is very, very easy, because so you have all the different countries we have focused on, and you can choose and have some additional information, because, for example, here in Romania, what is the situation there, the population, and the infection rates, and then you can easily scroll down here and see what are the results of the report, and then you can modeling things. And so for better service, we have some pre-selection sets included. For example, the old EU countries, the new EU countries, the countries with a low population, the countries with a high population. And for example, when we look here in the new countries, since 2004, we can see what is going on there. And if you want to have it more specific, for example, in the indication selection of higher risk groups, you have the results there. And so it's very easy for you to see what is the situation and how we can start to work on. And my message today is we have to start now, because this year we estimated to have hepatitis B and hepatitis C related liver deaths in Europe, more than 130,000. So, and in the last hour we're speaking here, around 100 people died again because they are not diagnosed and have no fair access to treatment. And we need to improve the situation now. Thank you very much.
Thank you very much, Achim. I think this was very important. This is a very important tool, and again, thank you very much to everyone developing this. May I now invite you, I think we have 5 to 10 minutes for discussion. I also would like to ask Beatrice and Arne also to join us here on the podium. Arne Björnborg, he is the chairman and chief operating officer of Health Consumer Powerhouse. And Arne, maybe may I ask you the first question? First of all, obviously, congratulations, this was a good work. When you have been involved in this project, were you aware of hepatitis up front? Was it completely new for you? Was it a new experience? Can you briefly explain how you address this one? You have the mic there.
Well, I think God had a hand in who we selected as project leader, because Bea has become our expert on indexes on diseases where prevalence data don't exist. She started with diabetes, which 5 years ago had very poor prevalence data. Then she got the HIV index, and I remember telling me, you'll get an easy one after diabetes, because if there's anything we know prevalence data on, it must be HIV, which turned out to be completely wrong. And we knew that hepatitis would be difficult, but I had no idea that it would be this difficult, which of course explains why there are no indicators such as drug use related to prevalence adjusted use per capita, because the prevalence data simply don't exist. And that was a surprise.
Do you have questions